shivering, sir.
Okay.
Post-op shivering, the frequent complication of anesthesia. Shivering is a syndrome involving involuntary oscillatory contraction of skeletal muscles. It is a physiological response to cold exposure and body. The next step in heat preservation after peripheral vasoconstriction. Post-op shivering, it is an involuntary oscillatory muscular activity during early recovery after general anesthesia. Shivering. Shivering is a fasciculation of face, jaw, head, or a muscle hyperactivity lasting longer than 15 seconds. The fundamental tremor frequency on electromyogram is more than 200 Hz. Two patterns of shivering, tonic pattern and clonic pattern. Tonic pattern is similar to normal shivering. A constant sinusoidal form of normal shivering seems to be a thermoregulatory to interrupt hypothermia. Clonic pattern specific to recovery from volatile anesthesia due to loss of inhibition produced by GA in control of spinal reflexes. Shivering is elicited when preoptic region of hypothalamus cooled. Effective signals mediating shivering descends in medial forebrain bundle. Spinal alpha motor neuron and the axons find a final common pathway for both coordinated movement and shivering. The typical cold tremor has specific rhythm in the form of grounded discharge and electromyogram. The tonic stiffening in a surgical patient, the non-thermoregulatory shivering in normothermic post-op patient. There will be two patterns. Tonic stiffening pattern of muscular activity observed as non-temperature dependent effect of isoflurane anesthesia. Second pattern observed was spontaneous electromyographic clonus, requires both hypothermia and isoflurane concentration between 0.4 to 0.2%. Shivering score is based on severity of shivering. No shivering, 0. Mild fasciculations of face, neck, and ECG disturbances in the absence of voluntary activity is 1. Score 2, visible tremors in muscle group. Score 3, gross muscular activity, entire body movement will be there. Causes: shivering usually triggered by hypothermia. Cold-induced thermoregulatory shivering remains the main cause. Other causes include pain, disinhibited spinal reflexes, and decreased sympathetic activity and respiratory alkalosis. Post-anesthetic tremor as anesthesia-induced thermoregulatory inhibition abruptly dissipates and increases the shivering threshold towards normal. The discrepancy between a persistent low body temperature and normal threshold activates the thermoregulatory shivering. Periop hypothermia, the core temperature of 33 to 35 degrees Celsius. Shivering threshold in non-anesthetized patient will be around 35 to 36 degrees Celsius. An anesthetic agent usually increases the heat response threshold and decreases the cold response threshold. So normal interthreshold range increases. A rostroventromedial medulla, which is the amount of pain and a temperature input ascending from spinal cord by getting the transmission of neuronal signals at the level of dorsal horn. Shivering, two types: thermoregulatory shivering and non-thermoregulatory shivering. Clinical features: usually shivering elevates the core body temperatures, increases the O2 consumption and induces lactic acidosis, and increases CO2 production and catecholamine release, and which eventually increases the cardiac output, heart rate, and BP. It also increases the intraocular pressure and intracranial pressure. Shivering impedes the monitoring techniques too. Associated with increased adrenergic, sympathetic hyperactivity, organ dysfunctions, and myocardial infarction. It also causes patient discomfort, increased infection, pain, any bleeding. Treatment, it includes non-pharmacological and pharmacological. Non-pharmacological, like forced air warming, is a method of active cutaneous warming, decreases shivering in period period. Surface warming interferes with peripheral input from cutaneous thermoreceptors. Passive cutaneous warming, like elastic bandage, cotton blankets, but has a limited benefit. Active cutaneous warming, like electric heating, water circulatory garments, and forced air garments, which is most commonly used. We can use warm IV fluid, which is most effective, and warm humidified air, which increases the core temperature and decreases the heat loss from respiratory evaporations. Pharmacological therapy, mostly opioids like meperidine and fentanyl, alpha-2 agonist clonidine and dexmedetomidine, anticholinergic spironolactone, and tramadol, NMDA antagonists like ketamine and magnesium sulfate are rarely used. That's it, sir.
Where did you prepare this from?
Sir, on article, sir.
Okay. So this is the same answer I had given in the earlier class for your seniors.